Yeah. So good evening, good morning, and good day to everyone. Why I am saying good morning? Because we have global members from different parts of the world here, and warm greetings to everyone. On behalf of Nephrocritical Care Society, it gives me immense pleasure to welcome you all to RISE. Yes, you are right. It's RISE, Renal Intensive Case Exchange. I am Dr. Tapas Kumar Sahu, General Secretary of the Nephrocritical Care Society. Now, little bit about this RISE program. RISE is a unique academic initiative. We thought about it last 4 to 5 months back, which is designed to bring the real world high stakes clinical dilemmas in nephrocritical care, particularly, and other allied specialties to the forefront, where we also sometimes confused between the protocols and how we decide at the bedside. Now, this platform is not about the textbook answers that we have read for last, like I would say, 10 years, 20 years or so. Rather, it is about thinking, debating, and also refining bedside decision. Now, that's why the concept of RISE has come, and today we are happy to have this inaugural session. Now, today's case, if I would be narrating in little bit time, maybe 1 minute, it truly reflects the philosophy of diabetic ketoacidosis. Every alternate day, we get a patient like this. Now, HSS, hyperosmolar coma, that is also sometimes like getting confused, like with the all the clinicians sometimes when they get a DK plus HHS overlap. So treating a single case is difficult. Now, when the cases are actually combined together, and we all know it as a DK HHS overlap. Now, if the patient is also having pre-existing cardiac instability, that is like I would say something nightmare for any clinician at the bedside. Now, the topic title for today, DK-HHS overlap with cardiac instability, a tightrope walk. Now, this is where like every standard step, what we all practice, that is the fluids, potassium, osmolarity correction, can potentially harm if not carefully individualized. The theory is okay, but in the real scenario, it is not always as expected. Now, this is exactly where the first session, or I would say the inaugural session of nephrocritical care RISE comes crucial, precision over the protocol. Now, we are privileged to have with us our esteemed subject expert, Dr. Raj Sekhar Chakravarti. He needs no introduction. He is the director of the nephrology and transplant sciences of the Jashoda Hospitals, Hyderabad. He is a doyen in the nephrocritical care and also very actively guiding us in our nephrocritical care every initiative. Now, I also extend a warm welcome to our session coordinators, Dr. Alisa and Dr. M. Ravi Krishna, sorry. So, Dr. Alisa is the consultant critical care at Some Ultimate Hospital, Bhubaneswar, India. And Dr. M. Ravi Krishna is the consultant intensivist at KIMS Hospital, Vizag. Now, I would be now handing over the topic and the discussion to Dr. Alisa Chaudhary to take over from here and lead us through this engaging case. Thank you, and let the learning begin. I request Dr. Alisa to please discuss and introduce the mentor and the mentee for our today's discussion.
Sure, sir. So, very good evening to all of you. As Tapas sir rightly said, this is a forum to basically discuss cases where things don't happen according to the what is mentioned in the textbook. Ideal case of DK or HHS, we know how to resuscitate them, how to manage. But what if it comes with a cardiac instability? To get more insight into this, let's first actually know in detail about what the case was about and how the case was managed. So for the RISE sessions, we have planned it as a mentor and mentee so that the mentee is a student, a third year trainee, or a new intensivist who's presenting, or it can be any intensivist who's presenting an interesting case. And the mentor can be from the same institute or from another institute if they ask for help to plan the presentation in a proper way so that the cases can be discussed well. So for our first inaugural session, Our mentee is Dr. Divya Patil, who's consultant intensivist in K.N. Rao Hospital, Salem, India. And our mentee is Dr. Amrita Shah, consultant intensivist from Medanta Hospital, Ranchi, India. So now I request Dr. Divya to actually start presenting her case and take us through what actually happened in this case.
Dr. Divya, you can make it presenter mode.
Right. Yeah.
Hello. So is the screen visible?
Yes, it's visible. And you're audible also. You can start.
Okay. So good evening, everyone. Today I'm presenting a case of hyperglycemia where both hyperglycemic emergencies, DK and HHS coexist with a cardiac instability, which is what we all as intensivists face, which is a tightrope walk. Coming to the initial case presentation, that is the patient, a 26-year-old male, admitted to the ICU who presented with chief complaints of altered sensorium for 3 days and history of loose stools for 3 days. So history of presenting illness on day one, the history was loose stools of 4 to 5 episodes per day, which was watery and non-blood stained for 3 days. And this was progressively associated with generalized weakness and reduced oral intake. Patient by day 3 had markedly depressed level of consciousness, and GCS on arrival to a local hospital was E1, V1, and M5. And patient was intubated at the referral hospital and referred to the higher center. On presentation, there was no history of fever, headache, blurred vision, abdominal pain, or vomiting. Few investigations were done at the referral hospital. Capillary blood glucose level were 600 milligram per deciliter. CT brain was normal. CSF findings were inconclusive. Coming to the past history, patient was a known diabetic and which was severely uncontrolled with an HbA1c of 12%. And there was a history of cardiac dysfunction, and a previous echo revealed an ejection fraction of 40%. On ICU admission, patient was unconscious. He was not responding to commands, but no, there was no fetal edema. Pulse rate was 92, a BP of 160, saturation of 96%, as patient with an FiO2 of 40%. Temperature was normal, and a capillary blood glucose at presentation was 557 milligram per deciliter. Coming to the neurological examination, GCS on arrival was E1, VT, M5. Patient was localizing to pain and he was unconscious. Pupils were bilaterally reactive. There was no focal weakness. DTRs were normal. There were no meningeal signs. Systemic examination was unremarkable. CVS S1, S2 was heard. There were no murmurs. RS, there was equal air entry on both sides. Vesicular breath sounds with no added sounds. Abdomen was soft and non-tender with no organomegaly. Coming to the initial POCUS findings, IVC diameter was 1.2 centimeters with a more than 18% distensibility. Ultrasound lung was A profile bilaterally with no B lines or no pleural effusion. An echo was done which showed global hypokinesia and an ejection fraction of 40% and no pericardial effusion, with a TAPSE of more than 1.7 mm and no RARV dilatation. E by E ratio was more than 1 and E by E prime was more than 15. Ultrasound abdomen was done, which was normal. Coming to the LVO to VTI, which was performed, and it was 14 centimeters. So at presentation, the glucose trajectory of the patient at presentation was sugar was 557 milligram per deciliter, and progressively as we started treating him, the sugars came down. It was 428 and 390, and progressive decrease in the values was seen. So on presentation, the ABG showed initial presentation, the ABG showed a metabolic acidosis, a pH of 7.1 and a bicarb of 13.1, and an anion gap of 20, and the delta gap of 0.8. So it was a mixed disorder with both high anion gap as well as a normal iron gap metabolic acidosis. The subsequent ABG showed a high anion gap metabolic acidosis with a delta gap of 1.26 and anion gap of 26.6. That was at the presentation. With treatment by day 4, the patient's anion, by day 3, the patient's anion gap had closed, and by day 4, the ABG had improved further, and there was no metabolic acidosis, and there was only normal anion gap metabolic acidosis by day 4. Now coming to the serial labs, at presentation, what was striking was the sodium values. The initial sodium at presentation was 178, and that was significantly high. Even calculating the corrected, the sodium levels significantly high. The potassium at present, there was also hypokalemia at presentation, and hyperchloremia at presentation, and hypophosphatemia. So after subsequent correction of potassium, the insulin infusion was initiated for this patient. And over the days, as we see, the sodium correction was carried out. And at initial presentation, the sodium correction was carried out, and the decrease was less than 10 millimoles per day. So significant values for this patient at presentation was there was a severe high anion gap metabolic acidosis, along with hypernatremia and hypokalemia. And serum osmolarity was calculated for this patient, serum osmolarity which was available, and that was 365 for this patient, was significantly high. And urine osmolarity was 500. Urine spot sodium was low, and FeNA was less than 1%. The other hematological parameters were unremarkable except the part the patient had mild anemia. And coming to the renal parameters, urea at presentation was 45 and creatinine of 1.7. Considering the FeNA as well as the previous values of FeNA and urine spot sodium being low, and the patient's clinical status of being dehydration, pre-renal AKI could be considered in this patient. The liver function test was unremarkable. Coming to the inflammatory markers, CRP and procalcitonin were elevated. Urine ketones for this patient was 2+. Serum cortisol and thyroid function were normal. As discussed earlier, CT brain and CSF were normal. So the serum osmolarity for this patient was 389, which was 94 milliosmoles above the upper limit, which is severely hyperosmolar. So in this patient, as we can see, the patient had a pH of 7.09, a bicarb of 12 with ketonuria, with the sugars being more around 600 at presentation in the outside hospital, and a serum osmolarity being 389 and GCS being 7. So it fits in criteria for both diabetic ketoacidosis as well as hyperosmolar hyperglycemic state. So the atypical factor in this case is the sodium being on the higher side. We expect the sodium to be on the lower side. So coming to the management of the patient. So the initial approach was to, as the patient's airway was already secured, it was to secure an access and then resuscitate with fluids, insulin and dextrose to be initiated after the potassium had been replaced and the other dyselectrolytemia was corrected, and specialist consultation was await. So at presentation, as the patient was intubated in the outside hospital, our ventilator settings were, patient was in a ACVC mode, tidal volume of 6 to 8 ml per kg with a respiratory rate of 24 to 30 to maintain a partial compensation for the metabolic acidosis, and a PEEP of 5 and an FiO2 of around 40% to maintain and titrate a saturation of 94%. At the same time, access was secured, a central venous line access was secured, and an arterial line as well as a urinary catheter was placed to monitor the output. So coming to this patient, the main thing was to calculate the free water deficit for this patient. The free water deficit for our patient came to around 11.4 liters. So since the patient had a low ejection fraction of around 40%, our plan was to replace it more slowly. And considering that he had also elevated filling pressures, there was a risk of flash pulmonary edema. So we replaced the fluid in a more slower fashion. we started initially with balanced crystalloid, and we had given him a bolus of 500 ml, and then we switched to 0.45% normal NS at 80 ml per hour, and also free water through nasogastric tube was given at 200 ml per hour 4th hourly. At each point, POCUS was performed to assess for fluid responsiveness as well as watch for signs of fluid overload. B lines as well as IVC and LVOT VTI were assessed accordingly, and fluids were optimized cautiously. Fluid boluses were given based on this assessment, and adequacy of urine output was maintained. And our target at this point was a sodium reduction of not more than 10 to 12 in 24 hours to prevent cerebral edema. And the blood glucose fall, we wanted a blood glucose level of less than 250 milligram per deciliter. And once the blood glucose came to less than 250 milligram per deciliter, we switched to 5% dextrose and 0.45% NaCl. And monitoring in this patient was continued with POCUS every 4th hourly for IVC distensibility, B lines, LV function, LVOT VTI, and to assess and guide the fluid tolerance, and to maintain a urine output of at least 0.5 to 1 ml per kg per hour. And also from clinical examination to look for lung auscultation and saturation or monitor for early signs of fluid overload. So coming to potassium and phosphorus replacement. So at presentation, patient had hypokalemia as well as hypophosphatemia. So POTFOS, which is used regularly, that was initiated. Once the potassium levels were above 3.3, the target correction for insulin would be initiated. So initially, we had initiated 20 to 30 milliequivalents of initially we had initiated 15 millimoles over 6 hours of POTFOS, and then subsequently potassium KCl was corrected with each pint. We had added KCl 20 to 30 milliequivalents to maintain a target potassium of 3.3 to 5. And the insulin infusion was initiated only once the potassium was more than 3.3. So regular insulin for this patient, since his body weight is around 70 kgs, regular insulin bolus was given 7 units and then followed by an insulin infusion of 7 units per hour, which was titrated to the blood glucose level fall of 50 to 75 milligram per deciliter. And sugars were monitored hourly. And once the sugars were less than 250, we switched the fluids to D5 and 0.45% NaCl. And the insulin infusion was reduced to 0.02 to 0.5 units per kg per hour. And the blood glucose was titrated between 150 to 200 milligram per deciliter. And hourly glucose monitoring was carried out. So as by day 3, the anion gap had closed. So we had planned we overlapped with subcutaneous insulin. A long-acting insulin was given for this patient, and a basal, that is the basal insulin, Glargine was given 18 units, along with the rapid-acting insulin, Aspart was given 6 units before each meal, and if required, bolus were given at that time. An endocrinology team was involved for further titration. So by day 4, coming to weaning, we had a weaning assessment of the patient because patient's GCS was improving. He was hemodynamically stable. The metabolic crisis had resolved. The anion gap had closed. The respiratory drive was adequate. And the FiO2 requirement was less than 40%, and he was maintaining a saturation of 94%, with no secretions. And the patient tolerated SPT without any distress and tachypnea. So extubation was performed, and the patient was monitored post-extubation for any signs of weaning-induced pulmonary edema, because since the ejection fraction was on the lower side, the patient was a high-risk patient. So coming to the key takeaways, in this patient, what was different was the hypernatremia at presentation. The sodium level was not high. It was not low. It was high. It could be because of osmotic diuresis and also because of the GI losses in this patient. And coming to the fluid resuscitation. So the fluid resuscitation for this patient will not be as, it had to be more guided by the POCUS as well as the echo, because it cannot be the conventional fluid resuscitation. It had to be more individualized for this patient.
Thank you, Dr. Divya. Dr. Alisa, you can
Yes. So
continue with
thank you.
moderation.
Yes. So
Yeah.
thank you, Dr. Divya. That was a great summary of the case which you have presented. Now, because there were people joining in throughout the case presentation, if you could shortly summarize the case and give us the key takeaways so that we initiate a further discussion.
Sure. So it was a 26-year-old male patient who initially presented with loose stools and altered sensorium of 3-day duration. And on initial ABG, there was a severe high and ungap metabolic acidosis. And patient was found to have both DK. It fits into the criteria of both diabetic ketoacidosis as well as an HHS. That was an overlap. At presentation, patient also had hypernatremia, hypokalemia, and that could be basically a pre-renal AKI from the other factors that we looked into. That was the FeNA being less than 1% and patient being dehydrated clinically as well as from the investigations. And there was an ejection fraction which was 40%. There was a cardiac instability in this patient as well. So considering all these factors, the patient fit into the criteria of both DKA and HHS overlap with acute kidney injury and hypernatremia.
Okay. So we ask the mentor right now. For the trainees who have joined in the session today, Dr. Amrita, if you can tell us, like, what do you think were the points in favor of DK and what do you think were the points in favor of HHS?
Uh, Hello, everyone. Thank you, first of all, Dr. Tapas, at this outset for giving me this opportunity. And see, the points in favor of diabetic ketoacidosis, the pH of the patient was severely acidotic with a ketonuria. Urine ketones were positive, okay? And the bicarbonate level was quite low to begin with. So it fit the entire, plus an uncontrolled hyperglycemia. Patient came with a very high sugar. But when it comes to an HHS or a hyperosmolar hyperglycemic coma, the patient had an effective osmolality, which was quite high to begin with. It was 389 milliosmoles. And also, the patient was obtunded when he had initially presented. So these two were the parameters with a sugar level of more than 600 in the initial hospital presentation, so milligram per deciliter. So these are the couple of points which points in favors of a HHS. So DK HHS overlap is what we will call it.
But what about the hypernatremia? That's quite a paradox, right? I mean, usually it is what we teach our trainees that there should be a hyponatremia. It's usually a pseudo hyponatremia, and then we correct it with the blood sugar. But your patient actually had a hypernatremia. So it's a paradox. So could you explain why that could have happened in this patient?
So, ma'am, in this patient, hyperglycemia, as you rightly pointed out, it usually causes a dilutional hyponatremia, where water comes out of the cells and there is a dilution causing a dilutional hyponatremia. But in our case, as we start with the history of the patient, he had presented with diarrhea. So, excessive fluid losses of the patient. There probably he presented to our hospital 3 days later, right? So there would have been no oral intake for the patient. Sugar levels of more than 600. So he would have presented with an osmotic diuresis. So osmotic diuresis along with a diarrhea with no oral intake for the patient and obtundation. These are the pointers which probably would have led to the hypernatremia in this case. It was not loss of sodium, it was excessive loss of water as compared to that of sodium, which has caused this hypernatremia.
So, if I say that the gray areas in this case, the gray zones in this case were a lot, right? One was the DK-HHS paradox together. Then patient had come with hypernatremia. So then we obviously were worried what fluids to, give and like how do we manage the sodium and then the insulin because I think hypokalemia was persistent in the case. So, administering insulin to the patient, electrolyte correction. And obviously, as we are always taught, the fluid resuscitation, but this was a patient with an ejection fraction of 45%. So obviously, it's a concern for us to give fluids. Since we don't have Dr. Rajshekhar here, we will be discussing the questions with you and Dr. Tapas. So, Tapas sir, if you could tell me that this case, what would have been, the fluid choices, what do you think? How do we manage our fluid choices in this case, and how are we going to correct the fluid deficit when we face a issue like this?
Thank you, Dr. Alisa. And first of all, I would really congratulate Dr. Dibya and also Dr. Amrita for selecting such a very interesting gray zone area topic. And also, they have also treated this patient very well. First of all, congratulations to the team. Now, whenever the first treatment plan for any decay or HSS comes, it first revolves around the fluid. So fluid, what we know from our MBBS days related to decay and HSS. Now come to the topic or the case proper. Here it is not that simple. Here the decay, HSS, and also there is problem with the heart. Heart is hardly 40%. So the core principle about the fluid is not standing valid. Rather, I would say the notion should be resuscitate, but don't drown the heart. So that should be the way forward. Now, initial approach for me, if I would be at the bedside and you have also rightly treated the patient very well, it has to be modified from the standard decay or HSS. Avoid aggressive 1 to 2 liter bolus that we normally do with this type of single straightforward case. Start with maybe 250 to 500 ml isotonic crystalloid bolus, but you have to reassess every 10 to 15 minutes. That will be the first point. Now they're coming to the choice of the fluids. Now choice of fluid, all the studies that have been conducted in last maybe 10 years and that have shown that balanced crystalloids like plasmalide or ringer lactate age over the normal saline, because we know the complications or side effects of the aggressive normal saline resuscitation, that is hyperchloremic acidosis and the Ringer's lactate and the balanced salt solution that has also shown to have a better renal perfusion. That is one thing related to the nephrocritical care point. But yes, RL is acceptable if your potassium is not very high. Now come to the severe hyponatremia. If because we always get in HSS hypernatremia mostly, though it is a very typical case, we have got severe hyponatremia. But normally, if you are getting severe hyponatremia, you have to start with 0.9% saline, and that has to be again cautiously. And for the cardiac dysfunction, I would definitely at the bedside keep ultrasound guided fluids. I have to check repeatedly IVC variability, LV function, and also lung B line. So this would be in relation to the fluid type. Now coming to cardiac instability, if you are still your blood pressure is not okay, you have to go for the early vasopressor. Now vasopressor of choice would be noradrenaline. Consider smaller bolus 100 to 250 ml as you are having 40% ejection fraction. And again, it will not be always the static parameters or the ultrasound guided. Rather, I would also go ahead with at the bedside about the PLR, passive leg raising, and echo. My target, as we normally accept in our ICU, around 65 millimeter mercury, and also urine output has to be one of the your targets, that is around 0.5 ml per kilogram per hour, more than that. And again, the gradual osmolar correction, that has to be something we have to keep in mind.
Thank you, sir. Yes, very well summarized, sir. You also highlighted the importance of focus because this patient needs very guarded fluid resuscitation considering his cardiac condition. We have Dr. Yash Javeri here with us. He's an eminent figure in critical care in India. Sir, any thoughts from your side regarding this fluid choices and how could this patient have been managed any differently?
Is he in the panelist?
No, sir is. I will allow him to talk.
Okay. Yeah. Bhagyasri, you can make Dr. Yash Javeri panelist.
In the meantime, I'd like to point forward just one pointer. Our patient had actually a normal anion gap metabolic acidosis in the initial presentation, and he had come from outside hospital to begin with. So there was a question probably within the audience that why normal saline is not used in this case. This patient had received normal saline outside as well as in the emergency room. And looking at the first ABGs, we were a little concerned as whether to give normal saline or not. That's the reason why balanced crystalloid was started for this patient. I hope I have answered the question.
Yes, sir. Any thoughts from your side?
Yeah. Good evening, Dr. Alicia.
Good evening, Dr. Jess.
Good evening. Wonderful presentations and a very practical approach. And we see this situation every now and then. Not only compromised cardiac functions, at times patients were oliguric and then they come with DKHHS. That also becomes challenging at times. The management was practically a textbook based management. We focused on cautious, non aggressive fluids, which was very, very important. We must be giving small aliquots, as mentioned by Dr. Tapas also. We also generally prefer balanced crystalloids in such situations. Hemodynamic monitoring we initiate little early as compared to routine DK patients who probably can do without any significant hemodynamic monitoring. Insulin also, generally we start slow and controlled compared to a non-cardiac dysfunction patient because there is a risk of hemodynamic compromise especially if the cardiac function is preload dependent. So osmotic shifts and rapid glucose drop can worsen cardiac function. So these are my learnings and very nice presentation. I'm enjoying the discussion. Thank
Yeah.
you. Thank you,
Thank you
Dr.
very much,
Alicia.
sir.
Thank you.
That's quite well said, sir. So then the next thing would be Dr. Amrita. What do you think would be the causes of a comatose patient over here, and what would, I mean, your correction targets for the electrolytes, especially the sodium?
So the reason for the comatose state, first of all, hyperosmolar coma. One thing is that itself can be a state. Hypernatremia, patient is coming in with a hypernatremia, that also can result in such a comatose state. The third thing could be the severe acidosis presentation, the decay acidosis. So hyperosmolar coma with a hypernatremia state with acidosis. These are all the possibilities that might have resulted in this kind of comatose state.
Okay, and your correction targets for your sodium?
So the correction targets for our sodium, actually we had the target, ideally the textbook target is around 10 to 12 milliequivalent per 24 hours, correct? However, in our case, we had gone for a very slow correction because the fluid, in the initial first hour is for the circulatory deficit, where you expect to give the boluses, and then aliquots of fluid and giving a maintenance in the form of 250 or 100 or 250 ml per hour. That is what the usual norm is, or a textbook norm is. But in this case, we had gone for a slightly lower correction. And as we see the free water deficit in this case, that was very high to begin with. But giving so much deficit in 24 hours is absolutely not possible. Correct? So that's the reason why we had gone for a slower correction in this case. And regarding electrolyte imbalance, now this is a gray zone because in the textbook, ideally it is said, okay, 3.3 and then start insulin. But we as human beings, we will always have a tendency that the sugar levels are 600. Let's start off insulin and let's start off potassium correction at the site. And this patient also had presented with a hypophosphatemia. So similarly, that correction was ongoing. So we had given around 20 MEQ per hour correction initially in this patient. It was given subsequently until we could reach a target of 3. And then insulin was started at a low dose and then gradually increase for this patient. I would say we did not follow a standard textbook. Ideally, we should, but I'll be very honest, in this patient, the standard textbook was not followed, and that's a human tendency. And I hope we do understand that repeated potassium correction was done. The subsequent levels were low. That's the reason why the insulin levels had to be titrated accordingly, and then the corrections were given.
Yeah, very true. So yeah, sometimes we do deviate because what is in the best interest of the patient. So Tapas sir, do you think it was a pure prerenal AKI or an evolving ATN?
Yes, so that's a difficult thing to decide at the bedside, but I would say it's a dynamic continuum. It can it started with a prerenal and it can involve it evolve into the ATN. Now there are points in favor of prerenal and also points which would be favorable for the ATN if the patient is evolving into ATN. Now feature suggesting prerenal, the history is very suggestive. It is prerenal only. Severe dehydration is there. Lab findings, as I could see, the BUN creatinine ratio was more than 20. It was low FeNA to start with, and maybe the patient will respond to fluids if it would be prerenal. Now, these type of patients will be ultimately evolving into ATN. Why? Like you would be getting your creatinine to rise, and if you are doing urine microscopy, you will get muddy brown cast. And most of these patients, they start with prerenal, but ultimately end up with ATN, and there is also cardiac instability. So I would be keeping this as very likely initial prerenal progressing to ischemic ATN, because the perfusion may not be adequate, the renal perfusion, or if it would be delayed, if the patient comes later on, and we will be starting the resuscitation, or I would say replacement later on. So that would be ultimately going into ischemic ATN. So practical like a bedside approach, I would not label completely whether it is prerenal or ATN. Rather, I would be reassessing the trend dynamically. The urine output trend, the response to the fluids, whether aliquots would be responding to the hemodynamics or not, lactate is getting cleared, and also finally bedside focus, perfusion markers.
True,
So
sir.
that would be something from my side. Yeah.
Dr. Amrita, was ventilating this patient a challenge? Do you think you
So,
faced a lot of challenges while ventilating this patient?
in this patient, actually, we were able to adequately resuscitate without getting much of congestion. However, such cases can be challenging because initially they come with such severe acidosis that they have to be compensated for that. Plus, if the patients land up in congestion with an electrolyte imbalance, weaning and taking them off the ventilator would be extremely challenging. So that's the reason, in our case, no, we have not faced. But then this could have potentially become a challenging case if the patient had landed up in congestion and the electrolyte imbalances were not managed. The patients might have landed up with a severe respiratory and muscular weakness. Yes.
Now the
I would be adding one thing. No, coming to the ventilatory challenge, these patients we have to respect the Kusamal physiology.
exactly.
Because
That is
something no, in our spontaneously breathing patients, it's okay. Patient will try to hyperventilate to compensate the severe metabolic acidosis. Now, if the patient is right now intubated and you are starting ventilation mechanically, so you have to also respect the number of minute, the minute ventilation that you are actually giving to the patient. That has to be, otherwise what will happen if your ventilator respiratory rate is low, your carbon dioxide will rise, and ultimately what will happen, your acidosis will worsen and your cardiac instability will again worsen. Now contrary, if your respiratory rate would be too much, what you are doing, you are overcorrecting, and ultimately the patient is landing up in alkalosis. That would be lethal for the cerebral perfusion. So we are one side we are having the heart as a problem, the other side we are having the brain as a problem. So that's why we have to maintain a controlled hyperventilation and don't go for sudden normalization of PaCO2. That is sometimes at the bedside we try to go for normalization, maybe hyperventilate, and 20-25 we are targeting. No, we should be going with a permissive required hyperventilation which would be therapeutic.
True. So the most important question everybody has in the ICU while managing such a case is when to stop the insulin infusion. So Dr. Divya, do you want to tell us how do you decide to stop the insulin infusion in your ICU, and then we'll take some inputs from the experts also.
So initially, the main criteria to stop insulin infusion would be, one is the closure of the anion gap, and the patient is able to take adequately orally, and we have corrected the other electrolyte disturbances And since the patient is also on those, since this patient had a lot of electrolyte disturbances, and we have, so once the patient meets all these criteria, I think the patient has to be transitioned from the insulin infusion to a subcutaneous therapy. And this subcutaneous therapy has to be initiated at least 2 to 4 hours prior to discontinuation of the insulin infusion. And both basal and rapid acting insulin have to be initiated. So we usually initiate basal insulin like Glargine, that is usually comes with the brand name of Lantus. So usually initiate that, and then after which we start, once the basal insulin has been initiated, then regular insulin thrice a day for the patient has to be initiated according to the sugar levels and divided. If you're taking 50% has to be taken initially like as a basal value, and 50% has to be taken as a rapid acting. And the rapid acting is divided into 3 doses. With pre-meal, with each pre-meal, the rapid acting would be given. We usually use Aspart or Lispro insulin for a rapid acting insulin, and Glargine for a long acting insulin.
Okay. Yes, sir. We will definitely want your inputs on this.
Thank you, Dr. Alisha. Dr. Divya already has pointed out, but because this is such an important and the new trainees often miss the bus. Most of them and the non-intensive, they stop based on glucose alone. So the message should be loud and clear. We should stop only after resolution of ketoacidosis based on closure of anion gap, bicarbonate, more than say 15 pH improving. And most important, the patient's clinical condition should be improving hemodynamically stable. If we look at the cardiac insufficiency, patients with DK and cardiac insufficiency, we must avoid abrupt stoppage. What happens? Patients get better by morning. The primary wants to send the patient to the ward, so they stop infusion abruptly. There comes the risk of rebound acidosis and hemodynamic stress. So we must overlap, especially in patients with cardiac insufficiency, and we might continue with low dose infusion until there is full metabolic resolution in cardiac insufficiency patient as against normal patients with DKA. Thank you, Dr. Lisha.
Very correctly said, sir. Tapasya, you want to add something to this, or we agree on what the discussion
Yes,
is?
most of the things have been already explained, and yes, Dr. Jas has rightly pointed out, and also I would say Divya has also managed it very well. Yeah.
Okay. So before we summarize the case and take the audience questions, let's summarize the points and take audience questions. We are privileged to have Dr. Marlies Osterman also with us in this webinar. If we can get some thoughts and opinion from her regarding the question, if she's online.
I think she's, I think not right now available. Okay. So, yeah.
So, so if I summarize the case or the high yield points from this case would be, first thing is we need to know that, you can come across such a situation, the paradox that is a DK and HHS, so that we should be aware about that. And if we face such a case, that always demands an explanation. Compute and don't assume, that means always calculate your corrected sodium, estimated osmolarity, anion gap, and in such cases, free water deficit. Cardiac function changes everything. Be careful. We just cannot go on resuscitating a patient who has a cardiac dysfunction. Use your tools in the ICU to guide you through the resuscitation process. Potassium is a very important thing, which Dr. Amrita pointed out. You need to correct your potassium before you start insulin infusion. The osmolarity window is narrow when you're especially dealing with the sodium levels, too fast or too slow. Both ways it can damage. So a target of 10 to 12 sodium correction per day, milliequivalents. Guidelines are starting points, definitely. Our guidelines give us certain points to follow because it's a blanket statement. But when you counter such a type of patient in your ICU, sometimes individualization of care is more important than just sticking to the guidelines. And multidisciplinary input is mandatory, especially in these cases where you need the intensivist, the nephrologist, and even the endocrinologist input. So thank you, everyone. And now we open the floor to all the audience questions.
Yes, there are a lot of questions. Thank you, everyone, for sharing your valuable inputs and also queries. Dr. Venkatesh has actually asked a very relevant question, that whether we should be going ahead with the free water deficit in this type of patients. If everyone agrees, I can take this question.
Sir.
Yes,
Yeah.
sir.
Yeah, okay. So, for me, in this patient, like, decay HHS with cardiac instability, these patients would be shock prone, volume depleted, and I would be not having the priority of calculating the free water deficit in the step one. Rather, I would be first restoring the circulation by giving small guided bolus, maybe 250 to 500 ml, again, depending upon your assessment. Now, vasopressors, if needed, I would be starting it early so that I am not landing up in the ischemic ATN. So perfusion has to be there. Now, step two would be gradual osmolar correction, fluid plus insulin together to reduce the osmolality safely. Now, maybe at the step three, I would be thinking of free water deficit when patient would be hemodynamically stable. Now you are entering into the maintenance phase and you are still getting persistent hypernatremia. So maybe that time I would keep what should be my target sodium, and then I would be calculating the free water deficit. Now, if I am targeting sodium number, any number as a target, what would be the problem? We all know in decay measured sodium is actually misleading. So you have to go ahead in hyperglycemia, sodium appears low. So don't chase the lab sodium or the drainage. Focus on the effective osmolality, and also you need to be always starting with the perfusion part first, and then going ahead with the maintenance phase.
There's one question which I think it has been like asked by 2, 3 people. What do you do if the accidentally or rapid correction of sodium has happened?
That's a question to be really, really having like
Yes,
worrisome
sir,
at the
any
bedside.
inputs on this?
Anyone can take. Dr. Amrita,
So
if you get.
I'd be very worried if there is a rapid correction. So first of all, there are two things here. One is the excessive fluid correction, and the sodium, the rapid decrease in the sodium levels. So excessive fluid correction, if that happens, or this is a young patient we are talking about. The patient might land up in cerebral edema. So in such a case, I would rely on the optic nerve sheath diameter, even though in a hypernatremia case, they usually do not mention it, but if there is a rapid correction. And the second thing would be regarding the decrease in the sodium levels, and uh, uh, that's when I'll be absolutely worried if there is some kind of a brain dysfunction that the patient presents with. We have to be cautious of it and involve the necessary teams, which might help us. And I would like the experts to give their opinions on this.
Dr. Tapas, can I add one point?
Yes, please.
Yeah. So actually, the few things which I wanted to add. So ideally, if this patient was previously on heart failure medication, so he's probably on potassium sparing diuretics and all, which would probably hamper our electrolyte management. And like the clinicians have already pointed, managing a patient with low EF and who is dehydrated, giving him IV fluids, and also at the same time giving oral fluids, we actually cannot estimate the extent of sodium correction with the formulas which we usually have. So there are actually two techniques which few people have used to actually correct sodium as precisely as possible. So one is known as the DDAVP clamp technique, where we remove the kidney out of the equation when it comes to fluid retention. So we dose the patient with desmopressin or a very low dose of vasopressin so that we can actually correct the sodium. And like the few have already asked, it is not the rate of sodium change which actually causes neurological complications. It is the trend. If a persistently rising sodium or a dropping sodium continues over more than 24 to 48 hours, then we can have neurological complications. As long as you are monitoring sodium frequently, any rapid shift, even though it is large, the neurological complications are lower as long as the patient is a bit young.
Yeah, very
I
rightly
can
pointed
share
out.
the related articles in the chat if you want.
Please. So as Dr. Ravi Kishan pointed out, we must control the speed and not just target the number. While we look at hypernatremia, we must also remember that we all already discussed hyperglycemia will be causing dilutional hyponatremia. So as glucose levels are falling, sodium is naturally going up. So we should not count this also. And patients with cardiac insufficiency, hypernatremia can be associated with volume overload also. So we have to be very, very careful. What we do if we see sodium is rising very fast in any DKA patient, we at times shift from normal saline to half normal saline. And at times, if there is associated fluid overload, we give a small dose of Lasix if there is pulmonary edema or hypervolemia associated with hypernatremia. This is what we do.
Yes, yes.
So,
Agree, agree.
Yeah.
there's one particular question. Is there a role of antibiotics over here? And in this case, and
Yeah.
should we have started antibiotics?
Can I take
Yes,
this
sir.
question?
And what is the
So
choice of
whenever, yeah.
antibiotic if
So
added?
whenever we have a patient with DKA, we must try to find the cause. There is always a trigger for DKA. It could be very, very remote cause as a tooth abscess, or it could be a common sense cause like skipping insulin for a long while. So the source for trigger or source, what we call the source, we must be very, very thorough. And in Indian setup, infections come stop up in the differential for DKA triggers also. Most of the time in India, what we see is eye infection related triggers. So some antibiotic is judicious. What it should be depends on the clinical context,
Anna.
biomarkers, clinical pictures, and many other issues. In this particular patient, we must also look at the cardiac triggers also for the decay. It could not be just infection, it could be cardiac trigger as was in this particular case. So unless we are sure what is the reason for decay trigger, we generally give some antibiotic. And what is the choice? Early empiric depends on the context. It cannot be decided. Yeah.
Yes.
Yeah,
Thank you.
Dr. Thank you.
Yes, yes. Thank you. Thank you, Dr. Jess. There is a question about what would be the osmolar gap, its importance in this case, and any target of osmolarity correction. I would say it is a very high yield concept in
Yeah.
this case and for the examinees also, because the trainees are also here. I would take this question. Now, when we discuss about the osmolar gap, now osmolar gap, we all know this is the difference between the measured serum osmolality minus the calculated osmolarity. And we all know the formula. It is 2 into sodium plus glucose by 18 plus BUN by 2.8. That is the formula that we use. And the normal osmolar gap is around less than 10 to 12 milliosmol per kilogram. Now, in this case, if we will discuss the DKHHS overlap, now this osmolarity is increased due to glucose and also urea. Now, these are already included in the formula that we are like I have already discussed. Now, if your osmolar gap is very high, now there is a second part of the question. If it is very high, more than 20, so now we have to think of maybe this patient is having toxic alcohols like methanol, ethylene glycol, or alcohol ingestion, not typical of the pure DKHHS. Here it will not be very high. Now, why we want to do it, or like we have to care for it, because we have to be very sure whether the hyperosmolar state is due to glucose, not toxins. Because if it would be toxins, then we have to think about the alternate cause of the coma, because that would be toxic ingestion leading to the alternate sensorium. Now also, maybe if we will be confused, it would be going in the wrong direction for the management. Now, if we are missing it, maybe dialysis would be one of the requirement to remove those toxins to make our osmolar gap in the normal range. So I would be saying more important than the osmolar gap, it would be effective osmolality. That would be, I think, the most important, which is indirectly the tonicity, because we all know urea doesn't like have any tonicity. So it would be 2 into sodium plus glucose by 18. That would be the effective osmolarity, which is important because of this neuronal dehydration to just have a proper cause of the coma. Now, the third part or the final part of the question, the target of osmolarity correction. Now, for all practical purposes, the safe targets if we discuss, it would be less than equal to 3 milliosmol per kilogram per hour. That should be your target. You should not be rapidly reducing the osmolarity. Glucose fall, when you are discussing about osmolarity, you will be also trying to reduce the glucose. It should be 50 to 75 milligram per deciliter per hour. That should be your target per hour basis. Now sodium, it should not fall rapidly. You have to go for gradual correction, because if you are going for rapid fall in osmolarity, it will land up in cerebral edema that we don't want. Now, how to practically achieve this? Because this is a difficult proposition. You are also trying to reduce the osmolarity, you are also targeting the glucose fall, but it should be all in a gradual fashion by giving controlled fluids, not aggressive, just like a typical HHS patient. Here it will not stand valid. Insulin infusion, again, low dose, don't go no overdrive from starting point. Add dextrose, I would say, if your glucose is around 200, because you will be immediately landing up in 150 or so, that we don't want. And frequent monitoring, that is, I think, the way forward. So this is a little bit of complicated case, not very straightforward case. So everything has to be in a very much tightrope. That would be I would ending up.
So thank you very much, sir. So in the interest of time, what we will suggest is the doubts which other participants have, you can post it in the nephrocritical care group, or you can message Tapas sir directly regarding your doubts. He'll be available to answer that. The most important thing here is that this was an inaugural session, and we definitely want to thank all our delegates and all our panelists. We also further encourage all of you to submit such interesting cases which we can put up in the upcoming RISE sessions. We request like mentees to be students and mentors from their own institute, so that it will be a good encouragement and motivation for the students to perform. So Tapasa, do you want to conclude?
Yes, I would be concluding with one important thing. We have already got many invitations, or I would say the request for the cases, and the second case already have been finalized, and I would be sharing it. This is something again most important, and we normally get this type of patients in our ICU, though we are not very sure how to manage it. So that is pulmonary renal syndrome, and that would be, again, please stay tuned. We would be sharing the details about the this case, who would be the mentor and the mentee, and who would be disclosing the complications and how we are actually trying to manage it at the bedside. So we have rightly mentioned it, when the lungs and kidney both cry out for help, mastering the melody is the key. Thank you very much, Dr. Alisa, Dr. Ravi Krishna. Dr. Ravi Krishna, anything from your side before we conclude?
No, sir.
Thank you, Dr. Ravi Krishna.
Thanks.
Now, huge congratulations, I would say, first to Dr. Dibya for managing this case, coming forward to present for the first time in the inaugural session, and she did it very, I would say, confidently, and the patient also managed very well. Dr. Amrita, thank you very much for guiding her, and she and you have actually presented it very nicely and narrated it very nicely. Dr. Alisa, Dr. Ravi Krishna, you have actually moderated this session very well. And thank you everyone who joined. Dr. Jas, thank you very much.
Thank you.
Somehow I would say Dr. Rajsekhar Chakrabarti, who is the subject expert, could not join because of some last minute hospital assignments, and he has actually apologized, and he would be definitely sharing his expertise in the upcoming webinars. Thank you very much, everyone. Please stay tuned for our upcoming nephrocritical care initiatives. See you all soon. Stay safe, and happy evening to everyone.
Good morning.